Hi, everyone. Welcome. This is a webinar sharing family physician stories across Africa called Family Medicine in Action. It's being run by Wonga Africa. My name is Shubi Musa. I'm a professor in family medicine in Johannesburg. We hope this series will include lots of people across the continent in time. I think to give it some traction, there's some key, very prominent South Africans who have begun to share their stories. We've had a few. We'll be putting it up online on the website that you registered on to be able to see some of those stories that you might have missed. But we're very privileged to have Professor Mergan Naidoo, who is a prominent member of the University of KwaZulu Natal, the Department of Family Medicine there, and in eThekwini, Durban, South Africa. And he's going to share his story as a clinical head of the family medicine department at the Wentworth Hospital. And as he's titled his presentation, Confronting the First Wave, the Role of Facility Preparedness. So thank you very much, Mergan, Professor Naidoo. We really appreciate you spending a precious Friday afternoon, and all of you listeners that have joined us as well. Thank you for joining us. We really are privileged. So over to you, Mergan. You can share slides. I'll just give you, I think you might need some permissions on my side. There we are. So you can begin to share and share your story if you want, and we'll have a conversation as we go. Please feel free to add your questions on the Q&A. You also have the chat function. You can begin to contribute to that and have a conversation with us all. Thank you all very much. We'll chat. We'll listen to Professor.
Right, thanks Shabir for this invite, and welcome to colleagues from across the continent and far away. So just to let you know that I work at a district hospital. So if people are not aware of what a district hospital in South Africa, it's a level 1 hospital. In South Africa, primary health care is actually delivered by primary health care practitioners who are nurse practitioners predominantly. And they then refer their first level of care when they enter the hospital sector is the district hospital. So the district hospital sees patients from a wide range of primary healthcare clinics, and then patients are then triaged, if necessary, to higher levels of care, usually level 2 and level 3 hospitals as appropriate. So I'm going to talk about a hospital which is basically 73 years old. It's got aging infrastructure that hasn't been updated over the years. So we actually faced a whole lot of problems when we were confronted with the COVID-19 pandemic back in March of this year. So the outline of our presentations, I'm going to talk about how we used a task team for COVID-19 to deal with the issues of COVID-19. I'll briefly cover some of the roles and responsibilities, the administrative and environmental controls that we put in place. I'll speak very briefly about how we tackled occupational health and safety, maybe spend some time on PPE, the training that we had to do in the facility, and then I'll just end with some of the clinical cases that I've had to face whilst working at Wentworth Hospital, and then end with some personal reflection. So this is what we felt like at the beginning of March, when we knew this pandemic or the tsunami was going to hit us, and we were really not prepared. We as I said, we had aging infrastructure. None of us knew much about COVID at the time, except from what we were reading in the literature. And we really didn't have the necessary ventilation and capacity to ventilatory systems to actually manage the patients. I'm talking about environmental ventilatory systems in terms of making it safe for us to manage patients who enter the facility. So we decided to form a task team, which consisted of members of the hospitals. And this was to provide clear direction on patient and staff management during the COVID-19 pandemic and its impact on the services. We thought we'd monitor, evaluate, and provide ongoing leadership in the management of COVID-19. And we wanted to facilitate transdisciplinary collaboration among the various role players within the institution. So what we did is we convened these weekly task team meetings, which was extended usually on a Monday, which included the senior management of the hospital, because we thought that it was important to include them, because if decisions were taken, it had to be followed up, and they needed to take the responsibility to ensure that decisions were actually followed up and were implemented. And then we had a core team. Initially, we were meeting every day, but then gradually we phased it out. And now I think because we in a low level of infections, we just meet once a week, which is basically the extended task team. We wanted to ensure that the institution adheres to the national, provincial, and the district imperatives of the Department of Health. We wanted to monitor and evaluate the implementation of these guidelines and protocols to ensure effective adoption and compliance, facilitated the reorganization and improvement of the infrastructure to cope with the COVID-19 pandemic. As I said, we're a 77-year-old hospital. Facilitate the acquisition, distribution, and monitoring of PPE, and facilitate the optimization of environmental and administrative controls for the COVID-19 pandemic through a quality assurance process. Develop, implement, monitor, and evaluate plans to ensure healthcare worker safety, ensure effective and efficient patient triage and flow to mitigate risk, and develop and implement an efficient system of reporting for COVID-19, and then align clinical management of COVID-19 suspects and cases to the national and international best practices and guidelines. And in that, we were often ahead of the game when it came to implementing practices, because the Department of Health usually lagged behind the rest of the world when it came to using certain interventions. Develop local protocols pertaining to COVID-19 and ensure sustainable coordination and communication of all matters pertaining to COVID-19 in the facility. So the team consisted of people from management, so the CEO, the medical manager, nursing systems manager, finance and HR manager, the infection prevention and control manager, who's a clinical nurse practitioner, a quality assurance manager, who's also a nurse practitioner, the safety officer, who's an environmental health officer, and an environmental health officer. Clinicians, we had consultants and medical officers who are part of the team, and then other healthcare workers, which were nurses, usually the operational managers or the assistant nursing managers. We had a representative from radiography, pharmacy, and later on we pulled in social work as well, because she played an important role in actually helping us with the psychosocial support program. The supply chain manager was very important, especially with the acquisition of equipment. The chief artisan was absolutely key in ensuring that we improved our infrastructure. The unions, when we started, I chaired this task team, and when I started, the unions had riled people up so much that people went on strike. And, middle of March, here comes this big strike, nurses all toying. And so you had to deal with this. So it was quite a daunting proposition going into this task when we were so short of PPE at the time. And then we included community health workers in our outreach team, which we then found a role for them and how they link to us as a district hospital. So it's important to define roles and responsibilities for each team member, because initially, I ended up taking a lot of the responsibilities on my own shoulders because I felt it needed to be done and people weren't doing it. But later on, as I matured in the role, what I started doing is if people brought problems, I actually asked them to form a small core committee, and they would actually find a solution for the problem and come back with a solution. So eventually, people come with problems, they knew it was going to be kicked right back at them, and they would have to find a solution for the problems. Obviously, we provide some ideas of how they could deal with it. So eventually, problems started being sorted out by members of the team, who would then form small groups and would come back to the task team to say, this is what we plan on doing and how we take the problem forward. So the core team consists on management, the CEO and medical manager, who very infrequently attended, then the IPC and the QA manager, safety officer and the environmental health officer. So there were a few clinicians and then a few nurse operational managers and the chief artisan. So these were people who would meet on a daily basis, assess the situation, make sure that work action plans that were put in place were moving forward, etc. So this was a typical agenda. So we'd have an action list and look at progress. We'd look at PPE stocks. We'd get a feedback from occupational health update and the psychosocial support committee, report back from the COVID-19 areas, starting from the gate all the way to our COVID high care, reporting in terms of outstanding results, screening, deaths, and outreach, clinical management updates if they occurred, medical equipment and the state of medical equipment, what we needed more of and how we were going to acquire these, what we were going to do to improve infrastructure, update on training and any new matters that may have arisen. So in terms of the administrative controls, so these were the broad aims of the administrative. So develop and implement policies that reduce exposure, screen and triage patients and family members, offer enhanced medical monitoring of staff, provide all workers with job-specific education and training, because this was very important because, the mortuary attendants and the laundry people had a wildcat strike because they said, no, they wanted to be protected and they wanted hazmat suits, So it required lots of training and education to actually make them aware that they don't really need it and to get them to comply with the guidelines from the National Department of Health. And so ensure psychological and behavioral support is available to address employee stress. So what we did was to have a terms of reference for the task team. We developed a preparedness plan for the control of COVID-19 and TB, because we still see a lot of TB in our institution. And it's an infectious disease, obviously. And one of the problems we had early on in the pandemic was the lack of N95 masks. And one of the concerns that staff had was the fact that, you need an N95 mask to manage TB suspects. So we decided that we were going to screen patients for both COVID-19 and TB and move them away from the main hospital. And that's what transpired. We had a protocol for screening patients and staff, different protocols for screening patients and a different one for staff, flow chart for managing persons under investigation or COVID suspects and confirmed cases, and for protocol for testing patients and staff. So this was just the first page of the preparedness plan that we developed for control of COVID-19 and TB at the hospital. This was our stand. We also developed a flu clinic, which was outside the hospital. And this flu clinic would see your ambulatory patients who were stable. And so we had to develop an SOP for that as well. And this SOP ranged from human resource provisioning to how often it should be cleaned, etc. So it's always nice to have these things documented so you have a reference point when staff. And we obviously, these went through multiple versions and we kept on updating it as issues arose. So these were dynamic documents that constantly changed. So there was so much of confusion about PPE and which PPE to use. And this was a discussion we had with staff on an ongoing basis. And so we had to develop a PPE, SOP for staff, so that it was quite clear. And I think, you know, having the unions, they kept on bringing up issues that we hadn't thought of. It was good, actually, because it actually kept us on our feet. And one of the things of these protocols is to actually disseminate it. So what we did is we had developed a communication strategy to make sure that all staff were actually exposed to it. We tried going IT-based strategy for disseminating information, but the unions then complained, you know, that some people don't have access to smartphones, for example. And so what we did is we printed all of these protocols and gave each unit a copy of the protocols. And we went around, different members of the task team went around and discussed each of the protocols with staff in the various areas of the hospital. So this was just me at the outside the gate doing screening. So what we did is we said we'll start screening at 6 in the morning. And initially we didn't have anybody to do the screening. So what we did is we got all the managers to start work at 6 in the morning. And we would triage from 6 to 8. And I think that actually provided a lot of confidence from the staff. Staff felt like if the senior people were out there in the front line triaging patients in the morning, it actually gave them confidence in their management, and it allowed them to then sort of work with us. So we weren't just making rules, but we were actually part of the team delivering on what was required in the institution. So we were doing it outside, and you know, we had some bad days with bad weather, cold weather, and eventually this actually was only constructed way back in I think it was in September. But you know, with the Department of Health and its procurement processes, this was our screening tent. And so we tried to get this done. It took us almost 6 months to get this done. We made this request. It had to go through all the supply chain management, bureaucratic processes, and it actually only materialized in September. But be that as it may, it eventually did materialize. And now we're doing screening in this tent. We've actually opened the side, so there's good cross ventilation. So this is just a WHO guideline of how we should manage patients, and we basically followed this type of process when screening patients at the gates. So this is just our screening tool that we used, and as you can see, this tool also went through many iterations. And I'm not sure if this is, I don't think this is the latest version as well. So this was just an earlier version of the screening tool that we used to screen patients. And obviously, this also required us to develop a SOP for trainers on how to screen. So so we did a one-page training for all the staff who actually trained, who do the training. This is just a flow chart of how patients should be managed. And I think this needs to be explicitly clear. And it's something that we need to reiterate all the time in terms of identifying unstable patients and triaging them to the emergency room. And often we may get a PUI who's pregnant and in labor, and what happens to that patient. And so we just had this flow chart that was actually incorporated in the preparedness plan in terms of what would happen between 6 o'clock and 4 o'clock, which would be your normal working days, and then from 4 p.m. to 6 a.m. and on weekends in terms of where patients went to. In terms of A&E, after hours, A&E became the sort of the screening area. We had to demarcate two separate areas to isolate patients who were either PUIs or TB suspects. So then the Department of Health, we had already developed our tools, and then much later, this came from the Department of Health in terms of, so this came 2 or 3 months later, but it actually, we already had a protocol, and what we did is we used the additional symptoms and included it in our tool. And this is basically the self-screening tool that staff use on a daily basis. So they have to self-screen, and the manager has to sign this off, and this has to actually then be handed into our occupational health clinic on a weekly basis. The manager collects it on a weekly basis. So all staff are screened on a daily basis. And if they are identified as having any of the symptoms, they then refer to our occupational health clinic. I must say our occupational health clinic did a sterling work during the peak of the pandemic, because I think they were the busiest area in the hospital. And the staff there did some really great work. So it's important, as I said, to provide all staff with job-specific education and training. So things like clinicians in terms of clinical management around safety in the workplace, and the paramedical staff, nurses, and the allied healthcare workers, the human resource and the administrative staff. What we did is that we took different areas, and each of us went to these areas, providing the education. We then looked at the size of the areas. We actually measured it out and said, okay, for this area, only 2 staff needed to work. And we then worked with areas where there was congestion of staff, and we worked out on a plan to rotate staff so that they comply with because this is an essential service and it needs to go on. So we worked out on a system whereby people would come to work on a rotation basis. So for example, in pharmacy, which was very small and we had lots of staff, I think pharmacy employs over 40 staff, and the area was very small. So we initially worked on two out of 3 rotations being on duty. And then gradually, sort of as things improved, we moved it up to 3 out of 4 rotations being present on a daily basis. The cleaners, kitchen, and hostesses, the hostesses are people who actually go into the wards to deliver meals, and some of them have to go into COVID wards. And so we needed to obviously provide them with education so that they don't unnecessarily expose themselves. The porters and the orderlies, the porters transport COVID patients. So, and the orderlies are also responsible for carrying infectious material like infected specimens, etc. The laundry staff and the mortuary staff. And as I said, these staff were initially very apprehensive and they went on a wildcat strike, and we needed to actually get to those areas and provide the necessary education around what COVID is and how it's transmitted and how they can mitigate risk. So psychosocial support is a really, really important area. So you have to take good care of your employees. And this is what we emphasized throughout the entire process, because we wanted to make sure that all staff felt part of the process, and not that we, as the sort of the leaders in the team, were providing a very top-down approach to dealing with the pandemic. So we addressed all concerns that staff raised, and we created a Telegram platform. People would raise questions and one of the task team members would address it almost immediately. So it was pretty useful. And I think when people had questions and queries, they would raise it there, or they would raise it with us, through their managers, or approach us when we were walking through in the passages, and we would address it. So the psychosocial support developed much later, unfortunately, but it did develop, and we had some training from our district psychiatrist. And this team is now led by the social worker in the hospital, and she's doing a great job of actually getting people to meet on a regular basis to discuss the stresses that they've been exposed to at work, and actually to work through all of those. And they do them in small groups in the different areas of the hospital, and it's actually so far it's worked quite well. I tried to get this going with the doctors. Friday afternoon is not a good day, so I mean, 2 of us attended, so it doesn't seem to. The problem is that because doctors are so busy throughout the rest of the week, Friday afternoon seems to be the only time where we have less time, but I think people leave early on a Friday afternoon. So some of the resources we used was the South African Depression and Anxiety Group, and then we had online psychologists from UKZN who provided consultation, and we circulated these contact numbers for staff who were able to access it. And then we used every opportunity to allay stress, anxiety, fear, and then also reinforcing positive behavior change, constantly reminding people about masking when they're walking in passages, when they're sitting in tea rooms, etc. It's very important. And then later on, I think April, May, we started this whole process of actually involving our EAP, or Employee Assistance Program, whereby they would phone staff who were off sick because of COVID and find out how they were doing, because it's quite a daunting process of being diagnosed with COVID-19 and being isolating at home. And so it's important to give them a call every day to say that we're thinking of you and we hope you're doing well. Is there anything we can help you with, etc. So I mean, that telephone consultation costs very little, but it makes a world of difference in terms of supporting staff in the institution. So in terms of the environmental controls, we need appropriate ventilation. And as I said, we have these big wards with windows, and that's it. The infrastructure was aging. There was also areas about flow, triage, swabbing, and the isolation wards. We had to think about areas of routine decontamination, enhanced decontamination when somebody is diagnosed as COVID. And this often, when we first started, we had this mini outbreak of staff in the emergency department. And that resulted in us closing the emergency department for a prolonged time. And then we learned from that experience because there was no guidance from the department on how to handle these particular issues. And we learned from that. And what happened was that now eventually we were able to clean a unit within 3 to 4 hours and get it functioning again. So we learned from our initial mistakes, and I think it was pretty useful. How to handling contaminated waste and linen and dead bodies. So this is basically the guidelines from the WHO in terms of natural ventilation, mechanical ventilation, and then hybrid ventilation. And we'll speak a little bit about all of those because that's what we had in our units. So this is just the recommendation from the WHO in terms of what types of ventilation is recommended for the different areas of the hospital. And this was, we partnered with one of the NGOs because, as I said, waiting for the DOH will take you 6 months to build a tent for triage, but this was done in 1 week. Well, in 3 weeks, because we partnered with one of the NGOs, we raised funds and we built our flu clinic. So this was the old tennis court, and we built this clinic where it took us 2 weeks to raise funds and 1 week to build the clinic. And it's a really well-constructed clinic. So on the left, you'll see the tennis court before and then after we've actually built it. And it actually has open natural ventilation, allows for crosswinds, and it's actually quite a safe area for staff. We had specialized taps put in with elbow taps, and then an area on the outside which allows for great cross ventilation is where we did our swabbing. What happened is that one of our wards was condemned, as I said, because it's an old hospital. It was 77 years old, and this ward was totally condemned. The roof had fallen in, the walls were partially standing up. And so when the district manager came around looking for sites that she could establish as COVID sites, we said, yeah, here's this place that's condemned, nobody is using it. Why don't you look at converting it into a COVID ward? And voila, we received this state-of-the-art COVID ward. This is our COVID ward. It's got 2 beds in it. It's got positive pressure ventilation in the passages and negative pressure ventilation in the rooms. So each room has got its own ensuite bathroom. So this was actually excellent. And then we had an old creche that was no longer being used. On the left-hand side is this area which we established as our high care unit. So what was done to our old creche is it was converted into 8 negative pressure rooms, positive pressure in the passages and the antechamber, and a negative pressure room in the patient room with its own ensuite. So there's single rooms that had an antechamber, and this was fantastic because our sicker patients could be managed here, and we ended up providing high flow nasal oxygen, even invasive ventilation, intubation, CPR, and the works. On the right is me seeing a patient early on in the pandemic before this structure was actually built, and it basically looks just an open ward with air conditioners as ventilations. Important. So this was the unit in our department. So we have one of the wards. I received funding from an organization previously, and we converted an old condemned ward into a family medicine department. So we've got consultant rooms there, we've got patient consultation rooms, and we've got a seminar room for students there. And this is a toilet. So one of the things that we did very early on to make this compliant with COVID-19 is to introduce elbow taps. And the hospital didn't have funds, so I had to twist the university's arm. We had raised funds in our department, and I got them to agree to spend money on improving the taps in our bathroom so that we make it safer for students and for registrars and for staff. So not everything we were not able to achieve everything. So the Department of Health, after they've spent the money on those other facilities, didn't have money. So we wanted elbow taps, for example, in our labor ward, our PUI COVID labor ward, and we didn't get that. You can see it's still got the traditional taps. So obviously we needed to couple this with routine decontamination measures of dealing with infectiousness. So the environmental controls required us to think very carefully about how we ventilate our different areas. We looked at infrastructure and all of the other areas I've spoken about. And our IPC sister then developed a SOP for infection prevention, control, and environmental cleaning. It was a great addition to our protocols. And this allowed us to develop things like these checklists for people to use routinely when it comes to routine cleaning, about how they would dilute the sodium hypochlorite and use it to clean an area, because you don't have a cleaner with you 24/7. We had routine cleaning happening every 2 hours. But when a patient is discharged, say in the middle of those 2 hours, or if a patient is suddenly diagnosed as positive, the whole routine cleaning needs to kick in, because at the beginning, everybody had the expectation that there needs to be these deep cleaning episodes that need to happen when the diagnosis of a positive patient or staff member occurs. But gradually we broke down those barriers and said, you know what, we don't need to focus on deep cleaning. We need to focus purely on routine cleaning, and that will prevent us. We will continue to maintain the safety measures that we have in place. So that was very important. So as I said, with occupational health, we spoke about screening and the management of outbreaks. I mean, this was a big problem because lots of staff, there were sporadic outbreaks in different areas of the hospital. As I said earlier, the first one was in the emergency department, and then the so-called low-risk areas where people tended to think that they're low risk, were the worst parts. We didn't have as many outbreaks in our COVID wards as we had in, say, the postnatal ward or theater, because staff were thinking that all the COVID patients are in those dedicated areas. So they would let down their guard. They would have tea close to each other, etc. Because we had put in, a notice on each tea room to say, at any one point, only 2 people are allowed to have tea in this room, and this is where you need to place your seats, for example. But invariably, human behavior is what it is, and people would congregate close to each other during the tea breaks, and that's how the outbreaks occurred. So it was often, most of the other outbreaks that occurred actually in non-COVID areas. We didn't have any outbreaks in our COVID areas. It's just that people were probably a bit more careful about their PPE, etc., in the COVID areas. So the importance of stressing the workplace controls in distancing and hand hygiene and mask. And I spoke about psychosocial support. We offered free vaccination for influenza for all our staff at the hospital, and many of them took that up. And then we had clear protocols for testing and management of COVID confirmed and exposed staff. So, staff would come in and said, no, I've had it. And a lot of the time it was fear, because one person would test positive initially, and then we would have 40 nurses from the OPD would suddenly descend on our staff clinic. And then we had to then educate them as to what a contact is, for example. And, and often it's more about anxiety. And after 40, we would screen all of them, exclude most of them, and would eventually only test 5 of them because they were true contacts, for example. So, and PPE was a big issue with staff, and we had to deal with it on an ongoing basis. And with that, we reached out. I sent out a lot of SOSs to private organizations, and I was able to get PPE. I was able to get PPE from lots of private organizations. Gift of the Givers helped us. Members of the community helped us. People would contact me and say, I've got a few ladies together. We're going to be sewing masks together for you, and they sewed like 600 masks for us that are distributed. So before the department could even purchase these cloth masks, we were able to raise enough funds and enough resources to give each staff member two cloth masks. And so, the department is actually very short-sighted in that they don't think about all the contract workers. The cleaners are contract workers. The people doing the gardens are contract workers. And this was excellent because we were able to get these cloth masks and issued it to them, all these contract workers working around the hospital. And so I prioritized them in terms of distribution of cloth masks. And they even come back to me now when the cloth mask gets torn, they come back to me, and I've still got some stock, which I give them. So this was just basically the WHO guideline of what is appropriate PPE for the different types of tasks that you're involved with. So as I said, the N95, we need to keep a check on that all the time. And we were very proactive in ensuring that we always had enough stock. And if you look at our stocks in the hospital currently, I think we're better stocked than most of the other units. We've never, besides that first month when we had major issues with procurement, but thereafter, our stocks, from April onwards, our stocks have been excellent in terms of managing them. I mean, I reached out to quite a few organizations with visors. DUT, for example, provided me with I think a couple of thousand visors, and I'm still managing the visors at the hospital, and I replenish people's visors whenever they need. So all of these things need to be addressed on an ongoing basis. So when you meet, you actually need to make sure that you have enough stock of that. So training, as I've already covered, we tried the system of having IPC champions for different areas of the hospital. It didn't work out too well because the IPC champions themselves didn't seem to, the IPC champions identified by the IPC manager were usually lower level staff who are nurses, and eventually we took it on ourselves as staff team members to provide the ongoing education and training. And whenever there were some issues in the hospital, each of us would go to this area and then address these issues with staff. So the WhatsApp groups, so we have different WhatsApp groups. We have a WhatsApp group for doctors and we have a WhatsApp group for task team members, and that facilitated very good communication. And it allowed us to communicate real time and also be accessible to issues as they arose. And then with the Telegram, we had we invited all staff to join at the hospital, and that allowed us to post all the protocols that we developed, everything new that happened in the hospital, and to keep staff updated, but also to address concerns as they arose, because people would hear about things in social media, they'd bring it up, and then one of the clinicians or one of the nurses or the IPC manager would go in and provide them with the correct education. And then obviously we had a weekly roster of training for staff. In terms of the clinical management, so outpatient, we developed a self-isolation checklist and provided an advice, sort of one-page advice for patients who were self-isolating. So whenever we saw patients in our flu clinic, we would go through the checklist and identify patients who could be managed as outpatients safely, and then we would then send them off. And then we had inpatient, adult inpatient. We had a particular protocol for managing them, pediatric and neonatal management, because we offer an obstetric service as well, maternity in terms of antenatal care, inpatient, in labor and postpartum care. And then we had lots of critically ill patients who would normally go to level 2 hospitals. But for about 6 to 8 weeks, we were not able to transfer a single patient out of the facility because all the critical care services were totally saturated. And we had to then make a plan and deal with that. So I'll speak a bit about it. And then it's important to tell staff about the sanitizing of medical equipment. So this is an area that, we constantly emphasize the fact that you could be the vector of infection. And if you look at what happened in St. Augustine's Hospital, which was the first private hospital to be struck with this big epidemic, I think there were over 200 staff that were affected. We actually had to stress the importance of maybe sanitizing a stethoscope, for example, between patients, etc. And I mean, I'm at the moment very OCD about sanitizing. I sanitize my hands 3 or 4 times during a consultation. So, and then the medical equipment that we needed obviously were very important to support our clinical care. So we have this flu clinic triage tool that we developed. And so the staff there, when patients arrived at the flu clinic from 6 o'clock in the morning, they would see these patients. Using the South African clinical guidelines, they would identify patients who were unstable, and they would refer the patients straight away to the emergency department. So we had this triage tools. So in terms of any PUI who needed admission and was hypoxic, so those were the patients that we would admit. So the well patients who couldn't self-isolate, we arranged for them to be, the department arranged for these hotel facilities for these patients. So we would get them to these hotel facilities. So we wouldn't keep them in hospital. So the only patients we really admitted were hypoxic patients or patients with sort of uncontrolled comorbidities that needed hospital care. So we would do an ABG, and we would do what I call a PF ratio. The PF ratio is a PaO2 over FiO2 from the blood gas. So if it was less than 200, we would usually discuss these patients with critical care. Invariably, the critical care would say no beds for those 6 to 8 weeks. What we did is, the other problem we had was that, there was a point where we couldn't get a test in less than 10 days. So we would swab the patient and we had to wait 10 days for a result because the lab was totally overwhelmed. The lab couldn't actually deal with the numbers. So we were getting results 10 days later. So it was an absolute nightmare for us as clinicians. So what we did is we developed, for our inpatients, we developed a probability score. And so I'll tell you about how this sort of developed. So the high probability patients, we would sort of, we had two PO. So we have 8 beds in our sort of high care COVID ward. We have 22 beds in that new ward that was built, but that wasn't enough. So that's 30 in total. And then we needed another 25 beds, which was a general ward, which didn't have the ventilation systems of those two wards. So if the patient had a low probability score, that patient would go to that general ward. And the high probability score, we would admit those patients to the negative pressure rooms. And then the critically ill patient was defined as any patient needing more than 100% oxygen. So this was the probability score that we developed. And I must say it worked very well during the pandemic, because patients with a score of 9 or more were identified. So did the patient have a close contact with a confirmed case? Did they have an acute cough? Did they have a temperature more than 38? A respiratory rate, oxygen sats, recent loss of taste or smell? See, that's very specific to COVID-19. So that was given a score of 3. They have a high C-reactive protein, raised white cell count, chest X-ray findings. They had a ground glass appearance on chest X-ray. They would get a score of 3. We looked at D-dimer levels because that correlate very well with COVID-19 and if the patient had presented as a diabetic emergency. So this correlated very, very well in terms of being able to triage patients to our different facilities, different areas in the units in the hospital. And then one of the registrars developed this, actually. He developed a clerking form for our POI. So we developed so the clerking form basically looked at symptoms of COVID-19. So symptoms of COVID-19, and then a chronological history of events, allergies, etc., risk factors, habits, HIV status. We would assess the clinical frailty score. We'll do a social history, it's very important. Examination findings, including the vital signs, assessments, the bloods involved. We put the findings there, and then we do the probability score. We incorporated the probability, the oxygen requirements on admission, whether the ICU was needed, what happened to the patient when we discussed with ICU, etc. So this was an example of a patient that we managed in the hospital, and you can see this patient was actually 2 tests were negative, but this patient was COVID, because remember the sensitivity of our swabs are not that good. And it also depends on when you get this patient. So if you get this patient on day 8 or above, then you're likely to have a negative PCR test. So what we did is we developed a tool for nursing staff to monitor ECG, blood pressure, SATs, respiratory rate, pulse rate, and AVPU 2 to 3 hourly. Maintain oral nutrition and hydration. Consider IV fluids if oral is inadequate. We prescribe pain management. And we supported awake proning and position change. And we actually managed the comorbidities quite tightly. Lots of our patients on diabetes, who were diabetic, we put them onto insulin. We ensure that dexamethasone and clexane was provided. And then obviously we had different measures, measures to actually introduce oxygen. So we have this types of oxygen flow or oxygen continuum in terms of nasal prongs, oxygen, sort of non-breather masks, and the flow rate. And then we had high flow and CPAP available at the institution. So obviously we had high flow nasal oxygen and how we would use it. So the contraindications, how to use it, and how to strap the prongs. This was the tool that we used for nursing staff in the wards, and we linked it to their on and off shifts, etc., when they came on duty. And this is how they would monitor patients on 2 hourly. So these were hypoxic patients. And at the bottom is when to call the doctor. So these are alert signs for them to respond, to call the doctor if the patient has got a tachycardia, if the patient has a SATs of below 94%, mental status is not alert, etc. So as I said, we would have these measuring. And then for high flow, we would usually do a thing called a ROX index to calculate. If the ROX index was less than 4.88, we would then discuss with ICU or higher levels of care. But as I said, for 6 or 8 weeks, we just have to manage our patients on our own. So, so this high flow nasal oxygen, actually, there was conflicting evidence from the WHO early on in the pandemic, and we didn't get clear guidelines of whether it was actually beneficial. And, I think the first clear guidelines actually came from our colleagues in the Western Cape, where they actually show definite benefit in using this. So what happened was that we actually didn't have any high flow. And we started the procurement process quite early. I think it was around April or May to get the devices. We got the devices, I think, in August, 6 devices. But so we had to make a plan. And so I did some training for some GPs in the community. And very interestingly, there's a doctor who was doing virtual COVID care in the community. He was offering high flow nasal oxygen to patients in the community. And I then linked with him, and I did some training for his doctors. And I linked with Vapotherm, which is one of the companies. And he then linked me to his network. And they then provided me with one unit. They actually sponsored a unit. Vapotherm then gave me a unit to trial, which I borrowed. And I had this unit in my car when we needed it for a critically ill patient who we couldn't get into ICU. And I'll tell you that I think I've got the patient case notes on this presentation. So the 3 HVNIs and the 4 high flow nasal oxygen was occurred through donors. We've got an additional 6 which came late in the pandemic. Now we've got 13 high flow nasal oxygen units, and we've got 4 ventilators as well at our unit. So the peak was in 12th to 30th July. I had 3 high flow nasal oxygen devices, and we were struggling. And so the 4 units were acquired in August, and I think the one from the Department of Health took 6 months, and we only got it in late August. So these 4 units I got from the gift of the givers. So they donated 4 units. I had to make a call to Dr. Suleiman, and he was very, very gracious in providing it, because it was very disheartening to have those deaths occurring when we didn't have the facilities to manage them. This is basically the current situation in KZN. So we had this big peak in July, August, and the numbers now are quite low. I think we have about 4 positive patients in the wards at the moment. So this was a 52-year-old male, diabetic, not maintaining SATs on CPAP. We had him on CPAP because we didn't have high flow nasal oxygen at the time. The ABG was severe ARDS. I think his PF ratio was something like 59. We found 4 ICUs, no beds were available. They all agreed that the patient needs mechanical ventilation, but he was number 4 on the list. So I had this unit in my car that from the Sunday that I'd done the training, and I had to phone around to Dr. Omar, and I said, please, can you lend me the consumables? So Dr. Omar, I went and saw him in the middle of the night, got the consumables from him, and then drove to our unit, and we set it up on this patient. So this was basically this patient already on, you can see that his PO2 was 6.4, which is really low, and he's already on 100% oxygen and already on CPAP. And this is what we did for him. This is him in our unit, and we proned him, we put him on high flow nasal oxygen, and this is what happened afterwards. His respiratory rate came down, his SATs came up, and this was his follow-up blood gas on the high flow nasal oxygen. So it was a game changer for us. And so his PO2 was 8.5. Later on, we found, when we were able to actually get a CTPA on him, we also found that he actually had pulmonary embolism. So that was a bigger problem. And so anyway, we ended up managing him for almost 21 days in our unit. This is another patient who came in and needed high flow nasal oxygen, and here's the HVNI being used. This is the other unit that we have available from the gift of givers, and we've used. These are some of the additional devices we purchased in terms of the multi-parameter monitors that we use for monitoring patients. This is an 83-year-old patient, no comorbidities, admitted due to severe hypoxia. That was a blood gas, again, frailty score of 6, so she's quite frail, PF ratio of 72, very ill patient. Again, game changer, high flow nasal oxygen. And so we put on high flow nasal oxygen, and she made a full recovery, this patient actually. So the advantage of high flow nasal: patient comfort, the patient's able to eat, no need for a tight fitting mask, it's heating and humidification of oxygen, improve ventilation perfusion by decreasing your dead space and improving alveolar ventilation, decrease work of breathing. You can get a desired FiO2 and use devices after COVID-19. So what we've been doing is we've been using these devices after COVID-19 for our patients with PCP. We've been using it with patients with COPD. We've used it in patients with cardiac failure. So these devices are going to be put to use. I mean, recently we've had quite a few patients with PCP. I think they've neglected the ARVs. Some of them have defaulted the ARVs, and we've been putting them on high flow nasal oxygen. Often these PCP patients or PJP patients don't get accepted into higher levels of care, so we end up having to manage them. This is just an outreach. This is the outreach that we do. So we have this: once a patient is diagnosed as COVID, either as inpatient, outpatient, we then refer these patients to our outreach team, which is the primary healthcare nurse and community health workers, and then they follow up. And now the nurse practitioners go to patients' homes and they swab the family at the homes, so they don't have to come back to hospital. So that's been an important, and they also provide excellent education for the family and also assess the suitability of the family in terms of being able to self-isolate. And so that is very important, because if they identify that people in the house aren't able to self-isolate, then we then make arrangements for the patients to be admitted to one of the hospital facilities. This is for them to refer to us and for us to refer. So it's a bi-directional method of referral for us to them and then. So as I said, reporting to the task team daily in terms of all of those stats. District office, sometimes they want you to report like 5 times a day, which is impossible. We then told them it's not practical. We reported to them on a daily basis. And then obviously CDC and NICD. What I did is we registered with the NMC app, and all our cases got reported on the NMC app. And then I think there was the Minister of Health mentioned there was some spike in deaths in KZN, but it wasn't a spike in deaths. What had happened is that we had actually gone through all the deaths that had occurred, because remember I mentioned that some of these deaths that occurred were as PUIs. We hadn't even got the results back. We went back, and when we had time, we started auditing these deaths and finding out whether these patients died of some other problem or died of COVID-19. And once we looked at the case both from a clinical perspective as well as from the laboratory results, and then if the laboratory results was positive, we would be notified as a COVID death. If the laboratory results was negative, we would then assess the case on its merit and then decide whether to notify the patient as a COVID death. And so there was a spike in deaths, and people couldn't understand what. It was just us going back and actually making sure that we audited all the deaths that occurred during that period where we didn't know because we were so busy doing other stuff. And then we reported it much later. So in terms of my personal reflections, so what have I learned? Being a manager in a public healthcare is difficult because you constantly feel that you're swimming up hills. And there are some people who believe it is their job to put obstacles in your path. Teamwork can achieve anything. There's no problem that you cannot solve. I mean, if a problem today can be solved tomorrow. So just take a break, you'll find a solution. Today's solutions were yesterday's problems. Yeah. So look outside your institutions for solutions, very important. And reach out to people, because I think we found a lot of solutions outside of the hospital. So always focus on the positive qualities of the individual in the team. There will be mistakes, you need to put those behind them, and you don't need to be incriminating. You need to know how to deal with it in a positive way so that the person there actually learns from the experiences and then moves on and then becomes better for it. So one of the big problems that I realize is the DOH does not employ people who know how to solve problems. So, I don't know what criteria they choose for the employ people in management position, but they certainly, most of the staff that I've come across, they don't have problem-solving skills. So it's important to start developing this, to ask them to start thinking about problems from a different angle, etc. What would I do differently? Maybe not volunteer for the job, make sure that each person takes responsibility, and maybe also get them to engage with problems on their own before jumping in and finding the solutions, which is what I did at the beginning. But as I said, I matured in the role, and establishing the communication portal with all members. So, you know, I chaired this task team from March all the way to the end of September. And after that, I thought it was time to move on. And one of the person that I mentored, I handed it over to him. And I think he's doing a great job in making sure that the task team continues to function. Obviously, we're not as the work is not as intense as it was during that major period that we had in July and August, but I think the staff who are currently handling the pandemic are doing an excellent job. This is just to remember that we need to make sure that we follow these public health measures at all times. And I think if we're going to prevent a second wave, it's important that we reinforce that. So thank you for listening.
No, thank you very much, Mergan. A really comprehensive view on what's been happening at Wentworth, and I can see you've done a whole lot of work localizing stuff, and I hope you can share the slides, even some of the documents that I think you might have just had snapshots in those slides. I think people would find them very helpful, like your clerking sheets and a couple other tools you've pointed out too. I really am impressed that you've walked the talk, which is really what all family physicians ought to do. Do you mind just sharing a little bit? I'm not myself very familiar with Wentworth. I remember it only as the old surgical wards, and this is like decades ago. So what is its, what's the number of beds? What's the community it serves, and how do you connect up to it? It's now a district hospital. Yeah,
it's a district. So it was a tertiary hospital when it was established in 1943. In 2000, it was actually then decommissioned when Albert Luthuli was commissioned as the central hospital. And so for 2001 to 2003, it laid idle. Albert Luthuli was using it as a step-down facility. So the Department of Family Medicine then made a proposition to the department in about 2002, 2003 to commission it as a district hospital. We started as 20 beds, and now we've got 250 beds. It offers a full comprehensive package of service for a district hospital. So we have surgical services, we have obstetric services, anesthetics.
All managed by the family physicians.
Well, family physicians and medical officers, registrars and interns. And we serve a catchment population of about 450,000 people. And remember, this is a public hospital, so people don't pay for the services. So these are the low socioeconomic.
Right. In areas like, if you don't mind, just
so in areas, so the areas we serve would be areas like Wentworth for the Bluff, Merebank, Lamontville, all the way. But you know, the people, we're the first hospital as you come from the south. So we've been serving people Toti all the way down to Angababa, all the way down to the Eastern Cape.
I can imagine. It's actually a big old south, but it's a hospital in Durban. It's a long time since I've been in that kind of space, but thank you for sharing that. I don't see any questions, but I've got a couple myself, and we'll just, if you can answer a few of them, it'll be really useful. I think one of the key reasons we've set this meeting, this webinar up, is to try and show what family physicians do and their value add. And you've shown this huge amount of value add in responding to the COVID pandemic. What attributes do you think you bring to the leadership of a hospital as opposed to a medical officer, senior medical officers? If you were to look at district hospitals run by medical officers versus a family physician, what's the difference?
So I think my biggest strength is I have good communication skills.
Let me talk generically. Know the family physicians broadly, rather than just yourself.
Okay, so I think one of the important skills is the communication skills, and the importance of appreciating the team, that it's not me or I do, but it's what the team does. So it's important to actually believe in the team and work out ways of how you can empower that team to take better control of leadership issues within the institution. On a total contrast, I've been exposed to people in the Department of Health who are very autocratic. This is how it can be done. And invariably it backfires. So I think you need to take, the communication is the important is to be a health advocate. So the health advocacy is you have to advocate for your patients. We looked at how we can actually let patients' families know. It's quite trying to have a patient in hospital for almost 1 month. They're not allowed any visitors. And how do we actually do that? And so we actually roped the social workers in and got them to, we had to try to get a mobile phone. We had messages being shared between the social worker, etc. So it was very important to actually be a health advocate for your, and then I think the importance of being a scholar. A scholar is very important because especially with the pandemic, things were changing on a daily basis. So you need to be networked with the group out there, and see what's emerging on a daily basis, and be able to take some of that new science that was emerging and apply it way before it was even become a DOH imperative. So this is what we did actually. We started reaching out for high flow nasal oxygen way before the Department of Health guideline came out, suggesting is that that was included in I think it was the 4th or the 5th version of the South African guideline. So that was very important, being the scholar aspect. And then being a good clinician is obviously core to whatever you do.
Of course.
The other attribute I think is important is to be able to network with the community. I had to speak to the hospital board. I had to reach out to people in the community, and you'd be surprised how much they can do to help you. You need to address their concerns. The people in the community would contact me, and the staff eventually got to know that I was chairing the task team, and anybody this relative or this contact that they had would contact me to say, okay, we want to do something for the hospital. What can we do? And we would make a plan. And that's how we got high flow nasal oxygen. That's how we got masks. That's how we got PPE. So you need to be able to be seen to be part of the community that you serve.
Yeah. Do you think we are training? I mean, you've done lots of things. You're demonstrating all the characteristics of good family physicians. But are we doing the training well? Or are we we're doing clinical training, but are we doing the training to make family physicians mini Mergans?
So this is a discussion we had with Vanessa Birch yesterday. I hosted a workshop for Vanessa looking at a thing called entrustable professional activities, so EPAs. And I think we need to be transforming our curriculum in family medicine to EPAs. And built into those EPAs, we need to include being a community advocate, being a health advocate, being able to collaborate. And when our students leave the registrar program, we need to say, do we trust this person to actually go into the community, work with the community, and make life better for the community? So I think it's important. So, I'm going to be pushing EPAs, and I've already reached out to Louis, who does our portfolio. And I said, Louis, we need to establish a task team that looks specifically of realigning our portfolio around the EPA route. And we need to, because EPA are observable, they're measurable, they can be assessed. And
well, how do you measure and assess twisting arms? Because you did that. How do you measure that? Because that's not an easy skill.
Yeah, well, at a basic level, the basic level, you need to see what level you need to, obviously. I'm quite senior, so it's easy for me to twist the arm and to get people to be influenced. Somebody coming out of the registrar program may not be able to. So maybe it is probably a competency of an experienced family physician rather than an entry-level family physician.
Well, it's food for thought, because I certainly think the family medicine program is to give that experience into very clear, different, discrete skills. And I think the problem is that we haven't spent enough time thinking about those as part of our curriculum. How do you raise funds? How do you organize meetings? How do you do change management? Teamwork itself is so badly managed in the family medicine program. I think it's almost an assumed skill. Just because they know how to talk to a patient, they know how to talk to a team. But that's true. I think these are all very important questions. And thank you for providing us a very, very valuable insight into what you do, the amazing work that you seem to be doing with COVID, and I think in many other things that you aren't sharing with us. But I think that there seem to be no other questions. I think, Mergan, thank you very much. This has been very helpful. There's going to be, I hope your slides will be available if you don't mind sending them to me. I'll stick it up with the recording of this, and this will be available. And we'll certainly make sure that people know about it. So even if it is, just a few people have been with us this Friday afternoon, it's going to be out there, and I hope that many more people will see this and draw inspiration from the wonderful work you're doing. So Mergan, thank you very much.
Thanks, Shabir.
Take care
Right.
now.
Thanks
And
a lot.
thank you all. Enjoy your weekend. Be safe. Bye-bye.
Bye.